So we're going to come back together and hear some report outs. It was a great conversation. Don't worry, we're going to keep talking. No more presentations for the next half an hour. But we're going to report back from the groups, the two groups, on what are some of the themes, and then open it up for a conversation among the entire group. And then in the afternoon, we'll have a couple of inputs and then another chance to work in small groups, different small groups. So we're actually going to start with 1A. David assured me about, how do we do 1A and what comes before 1B. So 1A will report back. John O'Brien is going to share some thoughts from that group, and then we'll hear from David Atkins, and then we'll open it up for conversation.
Thanks, Peter. So I'll tee up Group 1A's discussion of what are the opportunities for various decision makers to use a segmentation strategy, how is it valuable, what are the limitations, et cetera. There was first a question about should we be thinking about this at the system level, sort of the local up approach, or the national level, for example, more of a top-down approach. But I think the group, by and large, agreed that segmentation is valuable because it has the potential to better shape pay-for-performance opportunities and other policy, and that's sort of big policy, not just laws and regulations. It's necessary, but it's not sufficient. And I think much of the discussion focused on some implementation issues. The customers for this work, it's important to make sure that we include policymakers from the payment reform perspective, again, both in private and public payers, delivery system leaders in a three-part strategy to be able to get actionable patient information, use that data to get data from your own system, then target patients through patient list development, validating that list with providers, and most importantly, getting providers on board with the approach. It's incredibly important that patients be part of this discussion, be careful that they identify with and aren't offended by the terminology chosen. And then, of course, payers are an important customer for this work. And that conversation teased out a tension between if you make the clinical definition of the segment the priority and then encourage or require payers to design their payment models around those segments and those definitions and those identified successful strategies, you will run directly into the payer-derived approach to how they develop the segments and what things they think they're willing to pay providers for. So again, sort of a real tension there between is this a payment-focused approach, is this a clinical-focused approach, and that really needs to be teased out before moving forward. The pie in the sky answer there is if we had segmentation that worked across everybody and it appealed to both virtually and physically integrated systems, it would be a step in the right direction. There was a reminder about the importance of sustainability and implementation. If the approach isn't actionable, don't bother. Do we have the capacity to actually do the targeting and the care necessary or appropriate for each segment? Do we recognize that some care models are or will be effective in multiple segments and not effective in others? So the importance of sort of a mapping or a crosswalking strategy. And then an incredibly important overarching focus on the need to be flexible regarding disparities, inequity, cultural competency, et cetera, when designing, deploying, and implementing all of the above. And then sort of transition to a conversation about, given what we know about high-need patients in these current activities, what are some important next steps? Where do we need improvements? Again, the importance of segmentation and how it affects patients and caregivers came up appropriately as sort of goal one. Engaging patients in their terms becomes essential and is hopefully better informed by the data. However, will they identify with, or is there potential that they'll resist these segments as labels? Is there a risk for a certain segment becoming a poster child for high spending or other stigma? People will transition between segments throughout their lifespan and their care journey. What does that mean in terms of access to care and other services? Do I gain or lose anything because of a transition from one segment to another? And then that, of course, raises the important question of, is there an uphill battle in trying to give different things or provide different access to different segments? The group felt, by and large, that it's easy to agree on doing this from a clinical, quality, patient, and provider satisfaction perspective, and yet we were reminded that if we don't have the ROI or the financial return on investment evidence or business case to justify this, it may be very difficult to move forward, or that pushback will certainly be experienced. And many of the sources of the data that we need to prove the ROI don't necessarily exist, because some public and private payers may not currently be paying or even have the mechanism to pay the people who are actually doing this work or being proposed as being part of the solution. So whether it's pharmacists, transportation providers, others, it's hard currently to provide the value because they're not currently being tracked in their performance. As we saw earlier this morning, the value of chart and EHR data and claims data and pharmacy claims data individually only tell part of the story. The appeal of combining multiple sources of health and medical data is obvious, as is how much more we could learn and act on by incorporating data from social services and other sort of off the medical grid providers. There are certainly examples of bright spots in sharing data in the mental or behavioral health and substance abuse communities, et cetera. However, some existing entities may see their data and how they use it as a competitive advantage. If you're a payer and you're doing population health or care coordination or an integrated delivery system and you see what you're doing there as an advantage, you may have difficulty wanting to give up your ability to be unique or potentially empowering a competitor to do what it is that you're doing. Another example of that is the trade-off between getting Part D data quickly enough to do real-time targeting and care coordination without accidentally telling every insurer, PBM, and pharmacy how much each other's paying for that particular product. There may be some operational issues about how do you get data from one place, sync them up, and make them actionable. It's really easy to talk about mashups at the 30,000-foot level, but just trying to put those databases together may prove to be challenging. And again, there's also a lot of data that we don't have and aren't currently getting because we aren't currently paying for it, and we're collecting that data from, in many instances, payment or encounter systems. So what types of things need to be built to be able to capture the data that we need to tell this story? And that's, by and large, where the group broke for lunch. We think all of those things could probably be broken up even further as it relates to how this all funnels into the design, organization, and financing of care. Obviously, that could be different at the private payer level. That could be different at the federal or state payer level. And at the same time, I think the group expressed value in trying to make sure that there was a seamless transition between those three sources. So, Peter, I'll pause there. Is it appropriate to ask others if maybe we missed anything?
Any others from Group 1A? That was an incredible summary. Let's say, having been in the room, I nominate you to be the permanent note-taker and reporter. But any other thoughts? I mean, I thought that was a great summation of our conversation in distillation. So, thank you. So we'll now turn to David Atkins and then open it up.
So we had a lively conversation, relatively unconstrained by the questions we were asked to address. So since those questions were well addressed by Group 1, we'll add some other insights. So one overarching one was mentioned, but the importance of the patient perspective, and Reverend Hansen made an impassioned plea that we are at risk of losing the needs of the patient and the caregiver as we think about data and payment and p-values, and that the high needs patient was the most acute example of the failure of the healthcare system to be designed around the needs of providers and patients, and that a critical issue is just the lack of communication among, whether it's among different EHRs or among different clinicians or among the different people who are involved in taking care of high needs patients. And that until we solve that until we think about those needs and the barriers to meeting those needs in a system that still consists of silos and EHRs that don't talk to each other, we were going to have difficult meeting them. There was generally broad support for the segments as developed, and felt that they were going to provide an important way to look for a scalable unit of care to help define what competencies are needed in the workforce to meet the needs of these different high-need segments. But the point was made that there probably are generalizable aspects that cut across the different segments, and that as we look at these segments and map successful programs to the different populations, we may actually find, when we look at it from a program perspective, that two segments that look different are actually served by similar looking programs, or that there are common elements that are in all the programs, each of the programs that address the needs of these segments. But the second point was that we should just start using these segments and learning from them by mapping them to existing data. And there was a proposal that maybe we could crowdsource this by some arrangement where, in return for providing some data, different systems would see how well these work for mapping the different populations within their data, and to see how well they're aligned to their program. One point about data, missing data, that was made by several people, especially the geriatricians, were the importance of functional status and the lack of functional status data, feeling that that was a big driver of needs that wasn't necessarily captured in the segments, and currently wasn't available, although one of our participants noted that there is apparently something coming in Medicare to collect functional status as a part of routine reported data. Molly Coy started out with the observation that this is already going full steam in health systems in the private sector, that they're already developing, they're already segmenting their population and putting together, whether ACO plans or other plans, they're already developing programs to meet the needs of the segments they are seeing themselves. And so that presents an opportunity to learn from them, perhaps a challenge in that they're working off of a slightly different roadmap than we're proposing. Some people observe that we need more representation from the people who are going to develop, either are responsible for the electronic health records or for the technology tools that are going to be needed to actually implement, to identify these segments, to implement the care programs for them, and to collect the data to analyze what's happening. And so there was I guess a suggestion that bringing those players into the conversation sooner would be important, if not only because they're going to be an important marketer of these concepts. There was a feeling that even we shouldn't get tied up in whether these are the perfect segments, that just providing some organizing framework will be a big help, that it may help, that we need to do some work with implementers to map what programs we already have, or that programs that have been proven successful, to see whether they map. But there may be, this work may identify programs that are needed. So, and we need to think about the what's going to be needed to meet the needs within these programs, what policy or payment reforms may be needed. but that ultimately at the level of the patient and the individual provider, we need to recognize that while there may be this sort of concept of mass customization, that we still need to allow for flexibility at the point of individual patients and providers. There was some varying discussion about data and methods. Some feeling we need to learn from the innovation that's going on in the field, and a concern that if we set the bar too high in terms of proof of what systems work or what costs are preventable or what outcomes are can be influenced, that we might stifle some innovation. I suppose I was one of the voices saying that we needed to be careful about having at least some kind of comparison group as we look for what things are successful, and arguing that we probably don't know, we certainly don't know as much as we need to know about which programs are really effective, not only for which segments, but also in which systems, and that the baseline that you're operating from can have a big difference in terms of what added value a special program will have. And then I think the last comment was someone who pleaded that we shouldn't be paralyzed by our broken system, and that that where things may not look like they're can be influenced in our current system, but that's because we haven't designed the system in order to deliver the care. So things that may look insoluble in our current system may actually be addressed. And they drew that analogy similarly to the patient who we think can't be influenced. The difficult patient or the resistant patient may often just be the patient who hasn't seen a care system that looks like one that's meeting their needs or one that they trust. So I'll close with that and ask other people to offer friendly additions and amendments. Did I lose my chair?
No. I was.
No, I think you did a great job. I think the one thing that really came home, that was really just the most, significant point was the only reason to do this, people, is if we actually think it's going to improve care. So like all this talk about typologies and segmentations, fabulous. But unless we really think at the end of the day it's going to trickle down and improve care for patients, families, caregivers, don't bother. And that was just an important reminder, and the rest of it I think you covered. And that you covered, I just said it again.
Frederick?
I was going to say you did an excellent job. Thank you very much, sir. And the only other point I would bring out, which I think that was a really rich discussion about, as these conversations tend to be, about what's the purpose of the segments or the topography, and why are we grouping these patients this way, and this question of, and again, not stopping, using them, letting us as a country iterate on these things, but to what extent do we actually validate the segments by actually observing that the needs of the patients do sort of cluster around specific things, and then two, I think. Fundamentally, there's this question that we struggle with quite a bit with the supervisor work that we've been doing around the country, which is fundamentally we're trying to drive value. And so are the segments themselves allowing us to drive value? And so the question that I raised was, should we be focusing on rising risk in addition to the folks who actually escalate all the way to supervisors or not? What's the best way for us to be able to segment these folks so that we can drive value, and both in quality and in cost?
Just a fast comment about the ACO piece. I think it's really, really important that we look at these typologies as crossing all populations, not from a payer perspective. Even with the ACOs, we're just looking at, from a payer perspective, who are the segmentations in this Medicare MSSP group or Next Gen ACO. the broader we can make this, including people who don't have insurance, the more effective I think it will be.